Hi, this is Dr. Akhtar Amin. Today's topic is orbital anatomy. The orbit is a pear-shaped cavity, as you can see. The stalk of this pear is the optic canal. This is the optic canal. Dimensions of the adult orbit. The adult orbit volume is 30 milliliter. It is pear-shaped. The orbital entrance. This is the orbital entrance. The height is 35 milliliter. The width is 45 milliliter. The orbit is bony cavity. It contains the globe, extraocular muscles, nerves, fat, and blood vessels. The orbit has a roof, a lateral wall. The orbit has a roof, lateral wall, floor, medial wall. First of all, the roof. The roof consists of two bones. One is lesser wing of sphenoid. This is lesser wing of sphenoid. The other is orbital plate of the frontal bone. This is orbital plate of the frontal bone. The roof is located subjacent to the anterior cranial fossa. This is anterior cranial fossa and the frontal sinus. A defect in the roof, it may cause pulsatile proptosis. Why? Due to transmission of cerebrospinal fluid pulsation to the orbit. There is a supraorbital foramen or supraorbital notch. It is located within medial 1/3 of the superior orbital rim. Here you can see. It transmits the supraorbital nerve. Supraorbital nerve is a terminal branch of the frontal nerve. Frontal nerve is a branch of ophthalmic division of cranial nerve CNV1. And there is lacrimal gland. It occurs here in the zygomatic process of the parental bone. Now the medial wall. This is the medial wall. It consists of four bones: maxillary bone, lacrimal bone, ethmoid bone, and lesser wing of sphenoid bone. The ethmoid bone, also known as lamina papyracea. It is a paper-thin and perforated by numerous foramina for nerves and blood vessels. The lesser wing of sphenoid, it forms the medial wall of the optic canal and the lateral wall of sphenoid sinus. The anterior and posterior ethmoidal foramina, they are for anterior and posterior ethmoidal arteries. The emissary channels in the ethmoidal bone can facilitate the spread of infection from the ethmoid sinus into the orbit. The medial wall is the most direct path to the optic nerve, and it can be used for surgical procedures such as enucleation or optic nerve sheet decompression. Medial wall also consists fossa for the lacrimal sac. Here you can see, and here also you can see fossa for the lacrimal sac, and DCR surgery, dacrocystorhinostomy. Here we go to this fossa and do surgery. Next is the floor. It consists of three bones: the zygomatic, the maxillary, and the palatine bone. Zygomatic, maxillary, and the palatine bone. The posterior middle portion of the maxillary bone. Here It is relatively weak and may be involved in a blowout fracture. And the orbital floor also forms the roof of the maxillary sinus. So maxillary carcinoma invading the orbit may displace the globe upwards. Fracture of the orbital floor. It involved the infraorbital groove, which contains the infraorbital nerve. It should be suspected in cases of orbital trauma associated with infraorbital hypoesthesia. Floor is also the origin of inferior oblique muscle, and floor is also the site of blowout fracture, trapdoor fracture, secondary muscle entrapment. Because the posterior medial portion of the maxillary bone here, it is relatively weak. This was about the floor. Now the lateral wall, which is the thickest and the strongest wall. It consists of two bones, the greater wing of the sphenoid, here you can see, and the zygomatic bone. The anterior half of the globe is vulnerable to trauma because it protrudes. The anterior half of the globe protrudes beyond the lateral orbital margin. So the anterior half of the globe is vulnerable to trauma. Here is a retinal tubercle called the lateral orbital tubercle. Small elevation of the orbital margin of the zygomatic bone lies approximately 11 mm below the frontozygomatic suture. This important landmark is the site of attachment for the following structures: cheek ligament of the lateral rectus muscle, the site of attachment of four structures: cheek ligament of the lateral rectus muscle, suspensory ligament of the eyeball, also known as Lockwood suspensory ligament, lateral canthal tendon, lateral horn of the levator aponeurosis. This is the lateral canthal tendon attached to the retinal tubercle. This is the orbital margin, also known as the rim of the orbit. The superior, lateral and inferior walls are thick. The medial wall is less distinct. The medial wall blends with the contour of the nose. From above you can see the margins of the orbit. Here you can see the medial wall faces directly forward, while the lateral wall is angled outward at 45 degrees. This is a very important slide. Superior orbital fissure. It is a slit. It links the cranium and the orbit. This slit is between the greater and lesser wing of sphenoid. This slide is important because a number of important structures pass through this superior orbital fissure. It has a superior portion and inferior portion. Superior portion, it contains the lacrimal nerve, frontal nerve, and the trochlear nerve. These three nerves, and the fourth one is superior branch of ophthalmic vein. Formula for it is LFTs, liver function tests. The inferior portion contains the superior and inferior division of the oculomotor nerve, the abducent nerve, and the nasociliary nerves, and sympathetic fibers from cavernous plexus. The lesser wing of the sphenoid bone houses the optic canal. Another important point is the inflammation of the superior orbital fissure and apex. It is known as Tolosa-Hunt syndrome. It results in multitude of signs, including ophthalmoplegia and venous outflow obstruction. Another important structure is inferior orbital fissure. It lies between the greater wing of the sphenoid and maxilla, connects the orbit to the pterygopalatine and infratemporal fossa. Through it run the maxillary nerve, the zygomatic nerve, and branches of the pterygopalatine ganglion, as well as the inferior ophthalmic vein. Another important thing is the optic canal. It is 8 to 10 millimeter long. It contains optic nerve, ophthalmic artery, sympathetic nerves. Enlargement of the optic nerve occurs in optic nerve gliomas. Narrowing occurs in fibrous dysplasias. Blunt trauma causes optic nerve damage. Now, what are the clinical features of orbital diseases? First of all, the symptoms. Symptoms include eyelid and conjunctival swelling, redness, watering, pain, sometimes on or exacerbated by eye movement, increasing ocular prominence, displacement or a sunken impression of the eye, double vision, blurring, pulsing sensation, audible brew. Next is soft tissue involvement. Eyelid and periocular edema. There will be eyelid or periocular edema. There will be skin discoloration. There will be ptosis, chemosis. Chemosis is the edema of the conjunctiva, which may involve the plica and caruncle, and epibulbar injection. Here you can see chemosis and injection in orbital disease. The causes of soft tissue involvement include thyroid disease, orbital inflammatory disease, obstruction to the venous drainage. Next is important sign is proptosis. Proptosis is the abnormal protrusion of an organ, but it is generally applied to the eyeball. While exophthalmos refers to the specifically to the eyeball only. Proptosis may be caused by retrobulbar lesions, or less frequently a shallow orbit. The intraorbital portion of the optic nerve is longer. It is 25 millimeter. Then the distance between the back of the globe and the optic canal, which is 18 millimeter. So this allows for significant forward displacement of the globe. So this allows proptosis without excessive stretching of the nerve. Asymmetrical proptosis. Here you can see asymmetrical proptosis. It is readily detected by looking down at the patient from above and behind. There is left eye proptosis visualized from the above. This sign is known as Pfeiffer sign. Pseudotosis, it is false impression of proptosis. It may be due to facial asymmetry. It may be due to enlargement of the globe, for example in high myopia or ophthalmos. It may be due to lid retraction, or it may be due to contralateral enophthalmos. This picture contains bilateral proptosis in thyroid eye disease. The direction of proptosis is very important because it indicates the likely pathology. For example, space occupying lesions within the muscle cone such as cavernous hemangioma, optic nerve tumors, they cause axial proptosis, whereas the extraconal lesions usually give rise to combined proptosis and dystopia. Dystopia implies displacement of the globe in the coronal plane, usually due to extraconal orbital mass such as lacrimal gland tumor. Horizontal displacement is measured from the midline nose. Horizontal displacement is measured from the midline nose to the center of the pupil. Here you can see. While vertical dystopia is read on a vertical scale. This vertical scale is perpendicular to horizontal ruler. The horizontal ruler is placed over the bridge of the nose. The measured eye should fixate straight ahead. If necessary, facilitating this by occluding the fellow eye. The severity of proptosis can be measured with a plastic ruler, which is placed on lateral orbital margin. Here you can see. Or it can be measured by binocular X-ophthalmometer, Hertel or Lude. The corneal apices, which you can see here, they are visualized to determine the degree of ocular protrusion from a scale. Measurement can be taken both relaxed and with the Valsalva maneuvers. Absolute value is 20 mm or 2 mm difference between both eyes. It also varies with age. It is used for diplopia, difference between true and pseudo, for progression and outcome of proptosis, and the foot is placed on the lateral orbital margin. This is Nagle X-ophthalmometer. It uses the frontal and maxillary bone as reference points. Frontal and maxillary bone. It can measure both proptosis and hyperglobus and hypoglobus. CT scan can also be used to measure proptosis. Here you can see both the lateral margins. Line is drawn from one margin to the another, and here you can see the proptosis in this eye. Measurements are also taken during Valsalva maneuver. The patient exhales against the closed glottis. It can also show orbital varices. Next is enophthalmos. It is the recession of the globe within the orbit, or the retro displacement of the eye into the orbit. The causes include congenital and traumatic orbital wall abnormalities, atrophy of the orbital contents, for example by radiotherapy, and scleroderma. Here you can see linear scleroderma, and here you can see traumatic enophthalmos. Another cause is chronic eye poking in blind infants in the oculodigital sign, or sclerosis. For example, metastatic serous carcinoma, sclerosing orbital inflammatory disease. Pseudo-enophthalmos. It may be caused by a small or shrunken eye. Microphthalmos or phthisis bulbi. Proptosis or by the contralateral proptosis or pseudo-proptosis. This is the worm's eye view position. Note enophthalmos of the right eye. Another important topic is ophthalmoplegia. Ophthalmoplegia means defective ocular motility. It is very common in orbital disease. The causes include orbital mass, thyroid eye disease. Thyroid eye disease is a restrictive myopathy. In restrictive myopathy, there is thyroid eye disease. There is orbital myositis. There is tethering of the muscles or tissue after orbital wall fracture. Ocular motor nerve involvement associated with lesions in the cavernous sinus. Orbital fissures or posterior orbit syndrome. Orbital fissures or posterior orbit syndrome, for example, carotid cavernous fistula, Tolosa-Hunt syndrome, malignant lacrimal gland tumors, carotid cavernous fistula, Tolosa-Hunt syndrome, malignant lacrimal gland tumors. There are tests which are used to differentiate between a restrictive cause from a neurological cause of the ophthalmoplegia. Number one is force duction test. Under topical anesthesia, the insertion of the muscle in involved eye is grasped with forceps and the globe is rotated in the direction of reduced mobility. Checked movement of the globe indicates a restrictive problem. No resistance will be encountered with a neurological lesion. And there is differential intraocular pressure test. It involves less discomfort than force duction test and an objective rather than subjective endpoint. The intraocular pressure is measured in the primary position of gaze and then with the patient attempting to look in the direction of limited mobility. If there is increase of 6 mm of mercury or more pressure, it denotes resistance transmitted to the globe by muscle restriction. So in muscle restriction, there will be increase in IOP. This is known as the Braille sign. Braille sign. Saccadic eye movements, the third one, in neurological lesions are reduced in velocity. While restrictive defects, it manifests normal saccadic velocity with sudden halting of ocular movements. Eyelid abnormalities, common in thyroid eye disease. One is Van Graaf sign. It is a delay in the upper eyelid descent, also known as lid lag, during down gaze. So this is a normal person and this is a patient in TED. When he look down, there is a lid lag. Also, there will be retraction of the upper and lower eyelids. Now the dynamic properties. First one, increasing venous pressure. The venous pressure is increased by dependent head position, the Valsalva maneuver, or jugular compression. Jugular compression may induce or exacerbate proptosis in patients with orbital venous anomalies or infants with orbital capillary hemangioma. Pulsations. Pulsation is caused either by arteriovenous communication or a defect in the orbital roof. In the arteriovenous communication, pulsation may be associated with a brew. Pulsation is associated with a brew depending on the size of communication. While in the defect in the orbital roof, the pulsation is transmitted from the brain by the cerebrospinal fluid and there is no associated brew. Mild pulsation is best detected on slit lamp, particularly by applanation tonometry. Now, fundus changes in orbital diseases. Number 1 is disc swelling. Optic disc swelling, it may be the initial feature of compressive optic neuropathy. Compressive optic neuropathy. Optic atrophy, it may be preceded by swelling. It is a feature of severe compressive optic neuropathy. Important causes include thyroid eye disease and optic nerve tumors. Optociliary collaterals. Optociliary collaterals consist of enlarged pre-existing peripapillary capillaries. They divert blood from the central retinal venous circulation to the peripapillary choroidal circulation when there is obstruction of the normal drainage channels. On ophthalmoscopy, the vessels appear as large tortuous channels, most frequently sighted temporally, which disappear at the disc margin. The collaterals may be associated with any orbital or optic nerve tumor that compresses the intraorbital optic nerve and impairs blood flow through the central retinal vein. The most common tumor associated with shunts is in optic nerve sheath meningioma. Optic nerve sheath meningioma, but they may also occur with optic nerve glioma, central retinal vein occlusion, idiopathic intracranial hypertension, and glaucoma. Other sign which is choroidal folds, they will be discussed in detail in chapter 14. Choroidal folds may occur in a wide variety of orbital lesions, although they tending to be more common with greater amount of proptosis and anteriorly located tumors. In some cases, their presence can precede the onset of proptosis. Investigations, first one is CT or computed tomography. CT is useful for depicting bony structures, the location and size of space occupying lesions. CT is particular value in patients with orbital trauma because it can detect small fractures, foreign bodies, blood herniation of extraocular muscle. Can be used for blood, can be used for herniation of extraocular muscle and for emphysema. CT is unable to distinguish different pathological soft tissue masses because they are radiologically isodense. Confirmation of orbital abscess in cellulitis is a relatively common indication. MRI, magnetic resonance imaging. It can demonstrate orbital apex lesions, intracranial extension of orbital tumors, and for imaging orbital inflammatory disease. Serial short T1 inversion recovery known as STIR. These scans are valuable in assessing inflammatory activity in thyroid eye disease. Can be used for pregnant women, for children, but it is more expensive technique. So this is the CT scan, you can see the bones, and this is the MRI. Plain X-rays, they are little used except for the initial diagnosis of traumatic bone injury. Ultrasonography, they can provide useful information, particularly with high-grade apparatus and experienced operator, but does not image the orbital apex wall. Can be used for localization of foreign bodies, Doppler ultrasonography and vascular abnormalities. Fine needle biopsy, sometime performed, particularly in suspected neoplastic disease. Potential problems include hemorrhage and ocular penetration. The most common tumor associated with optociliary shunt vessel on the disc is an optic nerve sheath meningioma. This is the tip. Thank you very much for your time.